Good morning. It's great to have you here, and as I do for all of you when you arrive, before we start, I'm excited that you're here, and I'm glad that you arrive early. I really should have started with Jambo. Jambo is a Swahili greeting, and I've had a great 2 weeks in Africa, but somehow the weather changed while we were gone. It was 80 there, and I came back to 55 here in rain, so that's an interesting thing. I want to put in perspective what's happening nationally right now. Remember that Belgium went for over a year without a president. Now, Belgium's a little different country than the United States, but you know, I guess we're all kind of existing here. So this is a time for you to express your opinions to your legislators about their behavior. This is one of our series of ethics conferences, and I'm going to have Ben Wilfon do the introductions.
Good morning. For those of you who are new here, we actually have several ethics grand rounds over the course of the year, but every fall we have a particular one that's called the Truman Katz Lectureship. That is sort of the highlight of the year, where we try to identify a very distinguished person in bioethics who we want to address an important issue. And the Grand Rounds is also an opportunity for us to sort of pay tribute to Truman Katz, the former CEO of the hospital who the center is named after. And for those of you who are new, I want to tell you briefly a little bit about Truman. So Truman was the president and CEO of the hospital from 1979 to 2005. And he brought with it strong financial management. He secured broad-based community support for the hospital, and he built new and innovative programs to meet the needs of children. In particular, he developed a model medical school affiliation with the University of Washington. He worked to help create the Seattle Cancer Care Alliance, which is a very unique program between UW, Seattle Children's, and Fred Hutch, and really raised the level of Seattle Children's as part of that group. And he also promoted the development of a first-rate research program that has really also, over the subsequent decade, has really transformed Seattle Children's. Truman Katz actually has a long-standing history and interest in ethics, as you can see from when he was quite young. But he's been very much interested in the issues of quality of care. He's been very much interested in respecting the role of families. And he developed an emerging appreciation for the importance of both clinical research as well as complementary medicine. And both of these are areas where ethical issues are incredibly important. And he had the commitment to help develop the first Center for Pediatric Bioethics in 2005. And so our center has been going on for the last almost 8 years now, and it's really a pleasure for us to have this program and to honor Truman. So let me tell you briefly about our Grand Round speaker. So Ellen Clayton, we're very excited to have Ellen here. Ellen is the Craig Weaver Professor of Pediatrics and Professor of Law and the co-founder of the Center for Biomedical Ethics and Society at Vanderbilt University. She began as a lawyer, went to Yale Law School, and after she finished law school and was clerking, she kind of got more interested in medical stuff and figured the best way she could learn about medical stuff as a lawyer was to go to medical school. So she went to Harvard Medical School, and then after that did her residency at the University of Wisconsin, and subsequently has been at Vanderbilt since then. Ellen's primary focuses are on ethical issues of genetics. She's perhaps one of the most widely accomplished and thoughtful people in this area. She's been on the National Advisory Council for the National Human Genome Research Institute. She's a member of the Institute of Medicine, has been very active in a number of their various committees, and really has been thoughtful on a number of issues. And today she'll be talking about lessons from biobanking. So let me get back to my slides here. And Ellen, it's all yours.
Great, thank you. Well, thank you. It's a great privilege to be here at this great children's hospital and honoring this great man who played such an important role in the development of the work that you all are doing here. So this is a real honor for me. It's also, what Ben didn't tell you is that he and I were interns and residents together So we've actually known each other for a long time, and therefore know each other's foibles at a level that most people don't, not even my husband, I don't think. And I am, so I am here to talk about biobanking. And I have some disclosures to make, which is that I have no direct financial stake in biobanking. My research for a number of years has been funded in part by our CTSA, by some of our grants that deal with biobanking, and then frankly some of Vanderbilt's internal money, which has gone into the development of Bioview. I have also been thinking about biobanking issues for almost 2 decades, and about Bioview, which is Vanderbilt's project, since its inception. Actually, we started thinking about this in 2000, so I have a long experience with this. So let me say a little bit about Bioview, both in general and then focusing on pediatric issues. And then what I want to do in this talk, actually, simply put, is I want to talk about what is really involved in doing biobanking, and the complexity of the issues, and just some of the translational challenges that arise in this. And I'm going to touch on some of the hottest issues today, including data sharing, the current debate about de-identification and return of results. So this is a massive panoply of issues, but actually it's important to talk about all of this because all of these have to be considered as one is deciding what to do about creating a biobank. So first of all, you may have heard that Vanderbilt is what we call an opt-out biobank. What happened was in the mid-2000s, OHRP, the Office of Human Research Protections, actually looked at Vanderbilt's proposal, which was to take leftover blood specimens that were obtained in the course of clinical care. So, you know, if you're an adult and you go and get your blood drawn, they seem to sort of take 20 or 30 cc's of your blood and then use about 1 cc to test all the stuff they need to do. So the rest of it, they throw away. Well, what we proposed to do was to take this leftover blood, remove identifiers upon it, put it in a biobank, use it, do genomic sequencing, or at the time, gene chips, and use that for research. So that was the proposal. OHRP at that time decided that this actually didn't involve human subjects research because we didn't actually have an intervention with individuals specifically for the purpose of research. So in point of fact, what OHRP said was that in fact, the common rule didn't apply to what we were doing at all. So that's where we were. So a choice that we could have taken but did not take was to say, okay, we can put these things in this biobank and then anybody can use them for whatever they want without asking anybody. What you're going to see in the next few slides is that we chose to do a very different course with allowing people to opt out of being included in this biobank, and then putting in a tremendous amount of oversight to ensure the appropriate use of these resources for research. And so I'll talk about the review process. The other thing that we decided to do early on was to engage in considerable publicity about our program. So we had articles in both our Med Center newspaper and the local media. We had posters in all the phlebotomy areas. We had brochures that were available for patients to look at. We did a lot of work to try to help people understand what we were doing. So here's our current opt-out module. So what we chose to do at Vanderbilt was allow people to opt out of having their specimens used for this type of research, for Bioview. And the point that I want to make here is the way we do our consent to treat now, and this is available only for people who come in through the outpatient setting. It isn't available in the hospital for inpatients. It isn't available in the ER. And our thoughts about inpatients in the ER were that people would be too distracted to pay attention. So we only offer people this opportunity when they're outpatients. But what happens is that when they sign in, there's a kiosk, and it goes through the various pages of our consent to treat form. This is one of the pages, and the point that I want you to understand here is that it says that if I don't want to be in Bioview, check the box. But in order to be considered, and indeed for the slides, for the kiosk to advance, you have to sign this. If somebody hasn't signed this document saying that they've seen it, then they're not eligible for Bioview. So the opt-out is, it is a forced choice. Now the choice is you can say no rather than yes, but it is a forced choice, and this is what we, this is what we do. So this is, that's evolved over time. I can tell you that that was very complicated getting to that point, but nonetheless, we now feel very comfortable that people have the opportunity to look at this and to make a decision, and they have to sign the paper. Or actually, it's one of those screens like when you go to Dillard's, but nonetheless, but you have to sign this in order for it to go forward. So what do we do? What we do is that if someone, and this is really important, what we're talking about here is just the blood samples. It goes through a one-way hash, and the way this works is that every time a particular MR number goes through this hash, it comes out with the same number on the other side. This allows us to update the records going forward, but it also means that it is really impossible to go from this blood sample back to, from this DNA sample that we have over here, back to the original blood sample and back to the MR number. The other thing that's absolutely critical to understand here is that when you do research with biospecimens, if you don't have clinical data, you don't have much. And so what we also do at Vanderbilt is that we take our electronic medical record, or electronic health record, I know that's the new thing, and we also push it through the same hash. And we do this periodically that allows us to update it. But because the MR number goes through the hash the same way every time, and the hash also removes all the HIP identifiers and we have a number of natural language processing tools that we use to get things like the doctor's name out of it, or the wife of the governor of Tennessee, or the only pediatrician lawyer in the state of Tennessee out of the medical record. But it allows these things to be matched in order to be used for research. So this is our de-identification protocol. And so the idea here is to make it, well, the blood samples you can't, that in both cases, it's extremely hard to go back and re-identify these records. So here's some of our program review, and it is elaborate. First of all, we spent, just in initially setting it up, we went through many years of just deciding how we were going to do this in a way that was protective of the interests of patients, and went to OHRP twice, did a number of other things. And I'm going to show you a variety of different slides about this. That if an investigator wants to use samples from Bioview, they must submit a protocol to the IRB. Realize this is completely voluntary because it isn't subject to the common rule, but nonetheless, we do it anyway. It also undergoes ethics review and a variety of scientific reviews to decide that it is a scientific valuable study and that it's appropriate stewardship of the resources that we have. I will tell you that I see every single protocol that's submitted to Bioview, every single one. And I will also tell you that sometimes the protocols are actually amended based on some of the review that they get. We also do a lot of work with the communities. We have a community advisory board. We have ongoing research, some of which I'll tell you about, that looks at what the community thinks about what we're doing with Bioview. And all of this feeds back into the conduct of our resource. So very complex. This is another slide that talks about exactly what happens when a proposal is made to use Bioview. And it basically, I mean, I think these slides are going to be available to you, but the point that I want to make here is that there's a lot of review that goes on before an investigator gets the data they want. The other thing I'll tell you is that in terms of accessing data from the synthetic derivative about the phenotype that you're interested in, it is not as if the investigator can go and look through the 2 million de-identified medical records and just sort of fish for what they want. They have to specify at the front end what the particular variables are that they're interested in, and then staff within the synthetic derivative and within Bioview then go in and look for those phenotypic variables. So, you know, very controlled access. So just to be really clear about this. We also have a data use agreement that has teeth. One of my major concerns that I have had over the years has been that, that even de-identified, you know, there are concerns that people may misuse the data, they may use it for something other than the research they plan to do, et cetera, et cetera. And that some of the entities like dbGaP actually don't have any particular teeth to do this. Vanderbilt has real, honest to goodness teeth. This is what our data use agreement looks like, and I know you can't read it, and neither can I. But basically, what it says is that if you try to re-identify somebody, that bad things will happen to you, like you will not have access to Bioview anymore, that you will be banned from research, that you will be fired. And that not only do we do that, but we actually have additional surveillance of people who use Bioview to make sure that they're not trying to do things like re-identify people within Bioview and within the synthetic derivative. I remember when we were first involved with this, you know, almost 15 years ago, we were having discussions with the AMA, among others, in the late 1990s about how we could possibly monitor what people were doing with these electronic health records. And what I can say now is that we know how to do that, and we do that. And if people were to try to misuse the information in the synthetic derivative in Bioview, they would be caught, and they would have consequences. And they would be negative consequences. So, you know, so we take this very seriously. Everybody who uses Bioview as a synthetic derivative knows this, and so, and this is just part of the lay of the land. And so far, no one has been caught doing this, I think in part because they know that Vanderbilt is extremely serious about notions of consequences. We fire people every year for inappropriate access to the electronic medical record. So, just to be clear about that. Our genotyping process, and this is something that is really important for us in Bioview, is that when someone comes in and they want to genotype samples that hadn't previously been studied, that they make a proposal. Once the genotyping is done, all the genotypes go back into Bioview to make them available for other investigators. So allowing us to leverage this research for other research. We have, the last time I checked, we have over 180,000 samples in Bioview, of which about 60,000 have been genotyped in whole or in part. And we have a number of other programs in place. So that's what we do. And that's the important point. It's all returned to Bioview. Another thing that we've started doing very recently that I have to tell you I'm super excited about is that we've created a public portal about Bioview. Now, like everyone else, I'm aware that not everybody has access to the internet, but we really thought it was very important for those who did, for patients at Vanderbilt, or indeed for anybody, to know what we were doing with Bioview. And so we've created this portal that answers, and that's the URL for it, so you can go look at it yourself. It's available to anybody. But it says what we do. It talks about all kinds of aspects of Bioview. And the thing that is about to go online is that we already have a list of all the protocols that use Bioview available on the website. Most of it is written in science speak, so real people can't understand it. But we are about to roll out a list of protocols that are actually written in ways that that people can really understand. So we're very excited about that, making that available for people to know, in the process of transparency. Now I want to point out some of the unbelievable challenges in doing this. This is what I showed you initially about what our current Bioview system looks like. One of the things that we've learned is by using the kiosks, which make sure that everybody sees every part of the consent to treat form, is that we recognize that we have this language about Bioview, which we've used for, which we've now simplified into 6th grade English, a variety of other things like that. But our consent form, like many other consent forms, has language like you all have in your consent form, which says that when you come for care here, you can, we can take leftover samples, blood, whatever, and use it for research. There's no choice here, but it's, what's in your language. And what we're finding is, and you have nice language about the fact that you're going to de-identify this, all this sort of stuff. What we're finding is that now that patients can see our language that looks like this and the Bioview language, they get kind of confused. So I know, for instance, that UW is getting ready to roll out a project where they actually make this a choice for everybody. This is a big issue in this country that we're only beginning to address, certainly brought to the fore by cases like Henrietta Lacks, brought to the fore by the availability of the internet and some other stories like this. But just to be aware that this is standard language. And I wrote an article in 1995 where I quoted Vanderbilt's language that looked just like this in 1995. And so how we're going to sort this out is a really interesting issue. Our previous language in this, we've been through many iterations of language about the opt-out, in which we actually put all of this together. That didn't bother people. I think it's the idea that, that we force them to see it and force a choice, so we can make sure that there's a decision being made that has really brought this to the attention of the public. So I just want to put this out there as an issue that is becoming a very lively topic of discussion, and that will need to be considered as you go forward. Research on patient attitudes. We've done a lot of this, and so I'll just share some of it with you. We've looked at reactions and preferences in live settings where people face real decisions. We look at whether people how effective our communications are. We haven't done this recently. I think it's abundantly clear that they're more effective than they were. And then we've also looked at other relevant audiences, looking at both faculty and staff, and then particularly pertinent to you, the issue of parents of pediatric patients. By and large, people at Vanderbilt just love this. I mean, it's just, this is a study that one of my colleagues, Kyle Brothers, published a few years ago in the American Journal of Medical Genetics in 2 studies. One is that we did a survey of Vanderbilt faculty and staff. And I will tell you that my hypothesis at the front end was that faculty were going to hate Bioview. That particularly faculty from the non-medical part of the campus. What we in fact found was that that across the board, faculty, staff, wherever they were in the university, generally thought it was a good idea. And they were comfortable with DNA being used if personal identifiers were removed. They liked some idea about review by an ethics oversight board. Some of them, most of them weren't concerned about not getting written permission or written consent. The only real predictor or the only real correlate of people who didn't like Bioview was people who didn't get their health care at Vanderbilt. And probably that reflects the idea that they are concerned about their privacy when they get their health care in-house, and so they go elsewhere, and so they're not going to like this. The other study here used a community health survey where we oversampled for minorities in the Nashville community. This is important to know. Vanderbilt, Davidson County, which is where Vanderbilt is in Nashville, has 160 language groups. Who knew? I mean, you don't think of Nashville as being particularly diverse, but I'm telling you, it is. And so we did surveys for that as well. And again, by and large, they were favorably disposed toward the notion of Bioview, although they were more interested in giving written consent than others. So this is, some of our research some of our bigger studies that we've done in the Nashville area. Now, what about kids? We also have a freestanding children's hospital, not as old as yours. And so one of my colleagues, Kyle Brothers, went and interviewed parents of children who were being seen in two different sets of clinics. One is our outpatient, our general pediatrics clinic, which by and large sees children with Medicaid, or what we call TennCare, which didn't expand in Tennessee. And so that group of population, and then the other group that he went was some of the subspecialty clinics, which is a more diverse and socioeconomic status in those clinics. And he asked whether people would allow their kids to participate in minimal risk research. The overwhelming majority said yes. Whether they would allow their child's sample to be included in Bioview. Overwhelming majority said yes. Interestingly enough, the subspecialty parents were more likely to say that than the general pediatric parents, which probably makes some sense. And also that they were about as equal to do this for their kids as they were for themselves. So, and these were, face-to-face, semi-structured interviews. I'll tell you some of the other factors that emerged in sort of the more qualitative part. Of the 80-some people who were interviewed, only one preferred opt-in to opt-out. So forced choice to be in rather than forced choice to be out, which I think is pretty interesting. What they were particularly sold on is the fact that this is being created out of residual blood samples, so you didn't have to do an extra stick for their kid. And we all know that that's a big deal. So and boy, were they enthusiastic about that. They thought that was just awesome. We asked them, Kyle actually asked them, so is there anything about Bioview that makes you anxious? And the majority of them weren't even able to identify anything on their own. He then actually did some forced choices. He then say, well, what about privacy? What about a couple of other things? And the answer was that even when given a prompt, the majority of them weren't concerned. So I just am sharing this data with you about what people are thinking about Bioview, particularly in the pediatric setting. I want to say a few things about data sharing, because boy, this is a hot button topic, and but I think but there's a lot more work that needs to be done. And I want to point out that investigators aren't so excited about this. Or let me put it this way. They tend to be not so excited about sharing their own data. I can actually say that in Bioview, we're actually, that there's a general commitment to sharing this data, but I just want to put that out there. It promotes research, but people have desires to reap the fruit of one's own labor. There was an article about this in JAMA in 1995, comparing genetics researchers versus other researchers. And genetics researchers were more reluctant than other researchers. So there's issues of competition. Obviously, this is particularly true as we go forward in this current environment. The other thing is it's just plain hard to do. And I'm going to say something a little bit more about that in just a minute. But it's hard to share data. Some of the people in this room are part of the eMERGE consortium, which Vanderbilt is in and which UW Group Health is involved in. Coming up with shared, the genetics data isn't so hard. It's the clinical data that's just horrific. And thinking about how to do data mining in electronic medical records is actually really hard to do. It's really hard to do. And so, there are different IRBs, different community concerns, different formats. So although from an investigator perspective, it's more complicated than just say, well, of course we share data. And what do participants say about data sharing? This is from a paper that came out of the, I was going to say emerged from the eMERGE consortium, but that's a little weird. That came out of the eMERGE consortium a few years ago. And, people varied. They were generally enthusiastic. At Marshfield, only one person out of 1,200 opted out of data sharing. At Vanderbilt, actually, our patients tend to think that data sharing is a good thing and make them more willing to participate than others. In the group health cooperative, 86% consented to data sharing, general support. But there are concerns that people raise going forward, including whether the biobanks within government. I think we have to acknowledge that there are substantial parts of the population in this country who are deeply suspicious of government, and the idea that someone would put a database there is something that bothers them. It certainly was a major issue in Texas and Minnesota with the litigation about using newborn blood spots for research. Lots of concern about use by for-profit entities, which strikes me as a call for us to actually do better education about the fact that if people are actually going to benefit, like have this information be useful to inform their care so they get better health care, it's going to have to be commercialized some way, probably. And that we have to think about that rather than, and think about how to balance those interests as opposed to just saying per se no. And then people are concerned about risk of data sharing, and with some reason, I might add. So what do participants say about being asked? At Group Health Cooperative, a substantial minority said opting out was unacceptable. 2/3 said that simple notification was unacceptable, and that in this particular study, which was looking primarily at elderly patients, who, by the way, tend to be more favorably disposed to younger patients, were strongly committed to data sharing, but they wanted to be asked. So, so I think that's a reality. That's a community reality here. And one that one that needs to be taken into account. The issue with this issue about asking about data sharing is that it's required. For entities to get federal funding, they have to agree to data sharing. And the initial discussion about this was in 2008 when these requirements first put into place, and this was an outline that was put together by Laura Rodriguez, who in NHGRI, who's in charge of DBGAP, about how this actually kind of goes. But basically, in order to get funded, you have to agree to data sharing, and so that's a problem if your patients don't necessarily want it. I want to point out to you that 2 weeks ago, I actually think it was 2 weeks ago today, on September 20th, NIH put out a new notice of proposed rulemaking about genome data sharing, and they do a couple of things that I think are really important here. One is that they dramatically increase the number of biospecimens that need to be shared I mean, we're not talking about genomic data now. We're talking about other kinds of data, other kinds of samples as well. So they dramatically increased that. That's really pretty important. The second thing that they did that is very important is that they now require that there be front-end informed consent about data sharing, and they make clear that although people can place limitations on data sharing, that if they do, that this is a factor that can be taken into account in deciding whether to provide federal funding. So the incentive for, for healthcare institutions is to get broad consent for wide future use of this data without any kinds of limitations. And then the third thing they said that I think is very important, we all knew this, but the oversight by DB-GAP is actually pretty minimal. You heard me say that at Vanderbilt, we have consequences if people don't do the right thing. But the Data Access Committee, which is basically the enforcement arm within NIH, their only job is to see whether the use that the investigator wants to do is consistent with the informed consent document that the people signed. And they say that there is a requirement, at least for controlled access databases, that they can't try to re-identify, but there's no obvious mechanism by which that can happen. So, Jeff and I were talking about this, but this is really important to read because it requires a response, in my view. What about de-identification? In 2008, they talked about using the HIPAA identifiers, and this was the language that existed. And I'm going to back up a minute and just riff for a second. One of the things that is a real major problem in this area is that some people actually try to re-identify people and then publish it as hacking for the good guys, basically. And so if you may have heard in January that Jana Verlik and his team at the Broad published a paper in which they were able, using publicly available databases from Ancestry. People put all kinds of stuff out there on the web. I mean, just all kinds of stuff. So using these publicly identifiable databases that people put out there themselves, they were able to re-identify Craig Venter, which actually isn't hard to do since he put his whole genome and name on the web. But then a number of people in the 1,000 Genomes Project, they were able to identify that they were able to do that. And so, so the fact is, using the supercomputers at the Broad, that it's possible to do this. Now, the issue for me to think about, or that I would suggest that we ought to think about, is to say, so how do we set up incentives to make sure that people don't try to do that? What consequences can we put in place so they don't try to do that? And I can talk, more about that later on, but the issue is not, I think, necessarily to say that de-identification is impossible, but rather to say, what kind of investigator norms do we need to put in place that sort of define what's okay to do in research and what's not? My view that what he did was not. You'll not be surprised to know. And this is, and the way this eventuates is that, there are a number of people who rightly are saying that DNA can be identified under some circumstances, fairly unusual circumstances. You can do this. So, for instance, OHRP in their advanced notice of proposed rulemaking that came out 2 years ago decided that all biospecimens are identifiable per se. So, and so they therefore concluded that, that what is needed is a standard brief general consent form that grants unlimited permission for research uses. Now, they left open the possibility of opt-out, but fundamentally, this is a game changer if this comes to pass. And so this is a proposal that's out there on the premise that it's, that these are per se identifiable. Now, other things you could do is focus on use, but that's a different question. The Presidential Commission for the Study of Bioethical Issues, which is Amy Gutman's group, which has been tasked by President Obama, came out with a proposal that suggested that what is necessary is a robust and workable consent process with 5 specified domains. And then the new genome data proposal actually requires specific consent for data sharing, including whether it's going to be open data sharing a la 1,000 genomes, or whether it's going to be controlled at some level, although query how much control dbGaP has, and that people have to agree to that at the front end. The point that I want to make here is that, and my own point is that we ought to make clear that efforts to re-identify are unacceptable and have consequences. I mean, I think that's where we ought to focus our attention, not so much on this actually quite remote notion that people can be identified. So what we have here, and the reason I've spent a little bit of time, actually a fair amount of time talking about this, is that we have a lot of conflicting policies and positions that are out there. We know that people want to be asked. We know that data sharing is required if you're going to get federal funding. We know that data has to be de-identified at the same time that people are saying that that's not possible, and raising the question of whether it can be controlled. And I think there are real differences in what asking looks like. Does it have to be, I mean, if you looked at what was just proposed in the preceding slide, we had 3 quite different proposals about what a consent process ought to look like, or has to look like. And they are not commensurate, and they're not compatible. So this is sort of the shifting policy frame in which we're dealing in order to think about biobanking. I'm going to say a little bit about returning research results, and I'm going to really fly through this because I'd like to have some time for questions. There is, we can talk about returning nothing. We can talk about returning everything. We can talk about everything in between. We can have a debate about what constitutes incidental findings. Is it what you stumble over, as we had in the quality control experience in PREDICT? Is it pleiotropy? And then finally, as the American College of Medical Genetics proposed in March of this year, they've created a duty to look. They identified initially 57 and then decided they made a mistake. 56 genes that have to be analyzed every time you do genome sequencing or exome sequencing for things that are not pertinent to the particular clinical question. This is a dramatic change, this duty to look, and so I just want to put it out there. Do we have to retain a way to return results? Vanderbilt has chosen not to do that. That is the consequence of our de-identification strategy. Is it immoral not to be able to return results? I mean, I think not, but others do. A lot of criteria about what needs to be returned. Proposals about returning results that go on for some time, where if somebody's in a biorepository, that they get results returned as long as the biorepository is in existence. And is there a duty to re-examine them going forward? So these debates are already on the table, but one of the things that I want to be really, really clear about is that whatever we're talking about with regard to the consent for creating a biobank, for thinking about data sharing, for thinking about asking people whether, what people need to be asked in order to be involved. Whatever we're talking about there, what we're talking about here in terms of informed consent is qualitatively different. If you're going to be returning results, then you really have to tell people at the front end that this is what's going to happen. And because, people may or may not want it, it may or may not lead them to be in the biobank or not. But the idea that you're going to get in a biobank and then get results that you didn't anticipate, that mandates a level of informed consent that isn't necessarily required by all the other issues that I raised. So who should decide if the criteria are met? Should it matter what the relationship between the investigator and the patient participant is? The answer to that is almost surely yes. It's one thing if you're a clinician scientist and it's your own patient versus a downstream investigator, you know, several states away who has no earthly idea who the patient is or anything like that. I think that that's a difference that makes a difference. And then who should return the results? Lots of questions about that. This is Susan Wolf's proposal that appeared in Genetic and Medicine last year about how to do, you know, about how to return results in biobanks. And I know you can't really read it. The point that I want you to see is that this is really complicated. And that to actually make this happen is going to be really quite a complex set of concerns. I'll just also make a side comment about the issue of return of results and how it's played. The primary discussion has occurred in the research context, and that discussion has been largely agnostic of the issue of costs. It's now creeping into the issue of what we do in the clinical space, and their costs are absolutely going to matter. And we're going to have to take that into account as we think about policies in both domains. I put this in here just to show you that this is really complicated. This is our implementation map for PREDICT, which is our pharmacogenetic testing in the clinical space. And this is, you know, our B-School map about what it takes to do this. And the point that I want you to see is that it's really, really complicated. And it takes a really long time to get all the pieces in place in a way that is going to be sustainable in an institution. So here are my concluding thoughts, and then I want to open this up for questions. One of the main take-home message that I want you to get is there is nothing about this that's easy, not a thing. And that I was at a meeting on Monday where someone was asserting that obviously it's going to be inexpensive and easy to get consent for biobanking, and that we just really shouldn't worry about what it's going to cost. And I'm just here to tell you that that's nonsense. And you know, Vanderbilt has spent tens of millions of dollars in internal funding to get Bioview up and running. Now, it's a wonderful research tool. We have a lot, you know, we have been able to get a lot of grants. But to think that this is easy to do is just laughable. It just plain isn't. And then I think it's also important, particularly in the research context, to think about what it's going to mean in clinical translation, because after all, the point of your research is for clinical translation. I mean, you know, the public really wants us to do all this research and come up with things that are going to help real people in real time in the clinic, and that we need to think about the downstream clinical consequences at the same time that we're forging forward with this research. I'm happy to talk or answer any questions or respond to any thoughts. There are actually microphones.
I was interested because you mentioned Henrietta Lacks. I think just recently her family settled with Johns Hopkins about issues of informed consent and money. But one of their family's complaints was that her cells from her cervical biopsy went on to become HeLa cells that were extensively used in research and development of the polio vaccine, and that the family did not share in the financial rewards of that research. I was wondering if you had any feelings when these patients are consented, whether or not they would have any concerns that discoveries might be made that would have enormous financial implications, and that they might be cut out of that, much like Henrietta Lacks' family was.
Thank you for asking that question. So the other thing that I'll tell you that the Lax family got was that that actually the HeLa cells are now inside dbGaP, and that the Lax family is part of a group that oversees the use of these cells for research. Now they're not. I believe they have 2 representatives out of 6. Don't hold me to that. There's an article in Nature about it, but you know, which is really pretty unusual. I think the issue about commercialization is one that actually our jurisprudence goes exactly the other way. And for instance, the sort of seminal case in this area is Moore versus Regions of California. This is a case where John Moore had hairy cell leukemia, and it turns out that his leukemic cells generated phenomenal amounts of interleukins, and his clinician investigators knew this. This is what was alleged. Knew this, continued bringing him back, and the purpose was not to improve his care, but rather to get more cells so they could make more interleukin and make a ton of money. And the important point of the Moore case for this is that they said, and he sued for a cut of the profits. He also sued for fraud. And what the court there said was that he stated a claim for fraud, but he didn't state a claim for a cut of the profits. And so this has been, I think, an important one. There have been a number of other cases that have come up about issues of control of biospecimens. And by and large, the courts have been really hostile, would be a good way to put it. So I think that I think this issue about whether patients ought to be able to get a cut of the profits is, I think, an extremely difficult one. And I think the default position in general ought to be that they don't. So I think the Moore case actually should have gone the other way, by the way, because I think that they did that knowingly. But the idea of individual biospecimens leading to, hugely valuable outcomes is actually the wild exception rather than the rule. But I don't have a clear answer to that. I think there's so many other things going on in the Henrietta Lacks case, that I think there's the solutions in that case are going to be unique. But it's a great question.
I have a couple questions. One is about consent and how consent for use of your biospecimens can even be meaningful, because you can't. The consent is just, can we use it or can we not use it? But people don't know what it's going to be used for. It's not really meaningful consent. You can opt out of any use, or you can opt in for any use. And so it's not necessarily. I'm not necessarily speaking of your biobank, but just sort of specimens in general. And even that proposal from OHRP with there must be consent, but to me that's not meaningful. You can use it or you can't use it. So that's one of the questions that I have. Another question is how to address this sort of issue of posting all the data and how it's required for federal funding. I don't know what to say to the IRB when we tell the IRB, we have to do this. This is what we want to do. And I can feel the IRB saying, why do you have to do this? Why are you posting this data? Isn't there another way? So those are sort of the issues I wanted to raise.
Well, you might. I mean, if you think people ought to have choice about how their samples are used, then the fact that they make it a yes or no question means that they have a much more limited choice. I mean, that's all there is. And I think insofar as the IRB is concerned, if they don't understand that this is required as a function of getting the grant, then it becomes a real issue downstream, because it means the investigators, aren't going to be able to get funding because the IRB won't allow general consent. Now, my own view about this is that the IRB has some reason for concern. I think there needs to be a place where this data goes, where there actually is oversight and where there actually are consequences for misuse, and that, and then the IRB just has to decide if, if they think that this consent isn't sufficient, and so therefore, patients at your institution aren't going to be able to participate in federally funded research. That sounds a little paternalistic to me. I mean, that's the choice. I mean, because, and so, I mean, that's the choice.
So, Dr. Clayton, thank you so much for being here and for sharing your thoughts with us. We see Vanderbilt as a model. We're beginning this journey in biobanking. We visited your institution, and we really appreciate your leadership in this. I have a couple of questions. One is that as I read your opt-out form, it didn't say anything about de-identification. And was that a conscious decision? And I was just a little surprised because your original one did, but the one that you showed us, I think, did not reference de-identification.
I think there are a couple things to say about that. It's not as if that form is the only thing they see. There actually is an informational pamphlet that that addresses all those issues. And then, frankly, I think clearly as the regulatory climate changes, we're going to have to change what those things say.
Right.
I wasn't involved in sort of creating that new one, so I don't know exactly what the decision tree was.
Yeah. A second question is about birth dates. Does your de-identification process create codes for birth dates? And I have a very specific reason. We have a very, very open public information law here in Washington. There is an entire building at the University of Washington that employs people to Xerox everything, and it includes research data at the university. And we have had legal suits related to some of our studies because the birth dates weren't included. And if you get into a narrow enough disease or entity, having a birth date as part of the information really does allow identification of the person. And so I know that some of the data warehouses have a code that they jumble the birthdays that can be used for looking at dates or ages for the samples, but can't be tied back to. How do you do that?
I can give you the general idea. We actually we do a couple things. One is that the real birth date isn't in the de-identified medical record. It's done by ages. Done by years as opposed to dates. And certainly we have a 3-digit zip as opposed to a 5-digit zip. So a variety of things to really decrease the identifiability. The other thing that we do is that we date shift. And one of the things that goes through the hash is that my medical record, I don't know if I'm in Bioview. I can tell you I've never opted out, so you'll not be surprised to know. But every time my data goes through, for instance, it may be date shifted by 4 months, and that the person after me who goes through may have all the dates in theirs shifted by 3 months. So they're consistent. So for each individual record, they're date shifted by the same number, but it's not consistent across the whole electronic medical record. So there's a whole, you ought to ask, I know you're in conversation with some of the folks at Vanderbilt about how we do the de-identification stuff, right. But part of it is that we generalize the birth dates. Part of it is we generalize the zip codes. We do a lot of things like that, and then the other part of it is this state shifting stuff.
Oh, thank you. I don't want to monopolize this, but when you're looking at early childhood development, sometimes a year isn't adequate. You know what I'm saying? So So it is kind of a challenging issue, but thank you. Thank you.
Sure.
I can understand how it's far easier to have this de-identified in a one-way direction. But I wonder on the consent form whether there's any need to inform people that if a critical result comes up, they're not going to be able to learn about it.
Well, we don't do that. But I mean, I think maybe I should be really clear about this. We were talking yesterday about critical values in genetics. I don't think there are any. And I think that, I think in point of fact, in clinical care all the time, there are things that the lab looks for and that the lab doesn't look for, and that they sometimes will have critical values, but they're things that really are critical, like a potassium of 12. And so, so we don't, but that reflects a view that boy, the idea of returning research results is rarely justifiable.
Quick question.
Actually, I'm going to do the other, which I think you're doing, and that is, as the Time Nazi, I want to say thank you very much. I really appreciate the idea that you're providing for us about how complex it is to look at data, and you've heard some of the issues raised as you've already brought them up of how we both protect the patient and yet gain new knowledge. So can we give a big hand, please?